All right. Thanks for coming. I know that the fog has been an issue this morning, so we may have more people online, but we're glad to see that people are here. Today, we have a sponsored lecture. The lecture is sponsored by the Kennel Chair, which is in the Division of Pediatrics, Pediatric ID right now. And so we thank Kita Desai for helping us get this talk up and running. And Dr. Kennel was initially a neonatologist here, who then went on to become a behavioral and developmental pediatrician. And he is the forefather who began things like doula care for women. He's the reason men are in the delivery rooms here in Ohio and were in the 60s and 70s. And he's best known for his championing of patient and family-centered care. So Amy Edwards, who's from our division, is going to introduce our fabulous speaker this morning.
Thanks, Claudia. So I want to thank Dr. Vanderhoff for accepting our invitation to come and give the Kennel Chair lecture today. So for those of you who don't know, Dr. Vanderhoff is the director of the Ohio Department of Health. He leads statewide initiatives to modernize healthcare, enhance emergency preparedness, and strengthen Ohio's public health infrastructure. He was appointed by Governor DeWine in 2021. He has guided Ohio's transition from pandemic response to long-term community health improvement and workforce resilience. He's a physician, executive, and public health leader with more than 25 years of experience. Dr. Vanderhoff previously served as chief medical officer and senior vice president at Ohio Health. He has earned his bachelor's degree and medical degree from University of Pennsylvania and his MBA from Franklin University. His leadership has been recognized with honors, including the Phillips Medal of Public Service and Franklin University's Healthcare Hero Award. On a personal note, Dr. Vanderhoff works very closely with a lot of the physicians around the state. He and I have often done press conferences together and other community outreach around like the HPV vaccine and other things. And so we just met in person for the first time today, but know each other well for years, and just really appreciate you taking the time to spend with us. So without further ado, Dr. Vanderhoff.
Well, thank you all very, very much. Actually, what I'm going to do this morning is begin by talking at you, and then hopefully transition a little bit into talking with you as we go along. A little bit more about my background. So I can divide my career to date into sort of big clumps, and I'd say the first 15 years or so were spent in graduate medical education and undergraduate medical education, but mostly in the GME environment, where I ran a residency program early on, and then was the DIO for a big urban teaching hospital. Then I shifted, kind of to my own surprise, into being still involved with medical education, responsible for all the programs in a big health system, but was a physician executive with a big health system. But all of my focus during that time was on a combination of quality, medical education, and medical staff work and activities. So still very clinical. And during that time, I began one of the first hospitalist programs in Columbus, and most of my clinical work was thereafter in hospital medicine. So spent most of my time there, as opposed to early on where it was mostly ambulatory and in a primary care practice. Then early in the pandemic, you may recall in 2020, about a few months into COVID, Amy Acton, who was the director, left, and the governor, through some folks at Nationwide Children's Hospital who knew me, reached out and asked if I would be willing to come over to the Department of Health. And I really did not feel I had a public health background. And so I was a little hesitant, really not knowing if, well, could I step into that role and provide meaningful support? But they kept at it. And so in the fall of 2020, I came over, and I've been now over 5 years at the Department of Health. And the reason I'm sharing some of that detail is both so you can have an idea of who I am and how that may relate to your training or your career or where you're at, but also so that what I'm about to tell you about public health hopefully will have some more resonance, will have some more credibility, because I really have come to understand that public health is really probably not named properly. It's really an extension of all that we do. And in today's parlance, would be probably better off referring to it as population health or, macro community health or something, not public health. And I think the reason that it's, broadly referred to as public health is kind of how it started. If you look back, and we have lots at the Ohio Department of Health, we have lots of historical stuff and historical displays that are really kind of fascinating. But when you look at those, you see that early on, usually in the case of the Ohio Department of Health, this was the late 19th century, early 20th century. What were we doing? Well, it was tuberculosis. We were essentially we helped organize tuberculosis sanitariums. And there were physicians who today would probably have been infectious disease doctors, but were just physicians who had, special interest in doing this at the time, who were in charge of groups of people, mostly nurses, who helped with that work, and then reaching out into communities and coordinating communities all around TB. And it's really not until then the first major public health crisis of the 20th century, which was the Great Influenza, that all of a sudden these groups were, out of desperation, kind of called upon to help figure out, well, how are we going to respond to this? So then it slowly evolved, and it was really then post-World War II that you see more and more activities being undertaken. Now, today, the Ohio Department of Health has 175 different bureaus, all dealing with a whole variety of things, bureaus and programs. As I was looking at them and saying, well, how am I going to talk to people about that and put it into any sort of sensible structure? As I have looked at what we do, I can really break it up into three big buckets. The first bucket is preventative. We do a lot of work that you'd refer to as prevention. We also, though, do a lot of work now that's about urgent response to something that nobody planned for or expected. And I'll talk a little bit about that. And then we do a lot of work that's designed to reduce the burden of chronic disease. Now, there's overlap among all three of these buckets. If you're working to prevent chronic disease, well, you're doing some preventative work, obviously, but you're also doing some intervention to help manage the extent of chronic disease, hypertension, diabetes, obesity, et cetera. So I'm going to go through all of those. So let me turn first to preventive care. And probably the thing that we're most known for, if you were to say, what does the Ohio Department of Health or the Cleveland Department of Health, let me just back up real quick. So how is public health structured in Ohio? So there are states that are top down, and there are states that are more of a coordinating environment. Top down would be Pennsylvania. There, the State Department of Health has these bureaus distributed out in various parts of the state. Most states, though, are like Ohio, where there are local departments of health that are supported by a combination of local funds and state and national funds, mostly directed through the State Department of Health. But they're independent. And then there's the Ohio, the state level, in our case, the Ohio Department of Health. That's how we're structured. Pluses and minuses. When I get to urgent response, I'll talk a little bit more about that. And I'm posit that based on my experience interacting very closely with states that have the other model, while there are frustrations for me about our model, I actually think it's the better model than the top-down model for public health. So I'll explain that in just a bit. But backing up, vaccines are probably the thing in preventive health that people first think of when they think a Department of Health, whether it's Cleveland or the Ohio Department of Health. And I think there's good reason for that. I don't think there's any question that over the course of the past half century, there has been any public health intervention that's been more powerful than vaccines. They have just been staggering in their impact and their ability to transform the health of populations. And all you have to do is think about polio to see that. And my dad just passed away about 2 weeks ago. But I had multiple unsolicited conversations with him where he, in sort of watching things and noticing things, would on his own say to me, well, Bruce, you know, anybody like me who remembers friends of his getting sick with polio and then having, you know, lifelong disabilities, or remembers the utter fear that would settle on the neighborhood when there was somebody with polio, and then remembers when the vaccine became available, how people were like lined up, he said literally lined up around the block to get vaccinated, and that it just went away. So this, like, he said, it was like a frightening scourge, that it was almost like something that you looked upon as running the gauntlet. And were you going to run the gauntlet and come out unscathed? Or were you going to be one of the people who had, you know, died or had lifelong disability? And suddenly it was just gone. And so that's how impactful some of our vaccines are. And today, all we have to do is look at the resurgence, sadly, of measles. And, you know, you all know measles is a nasty disease and one of the most communicable diseases that we know. And it's also one that is almost entirely preventable. And that's because of the MMR vaccine, which is such a good vaccine. And I don't need to tell this audience how good a vaccine it is, or how safe or effective it is. And, you know, I have this little podcast I do, and I had Paul Offit, who, so, you know, I trained at Penn, and Paul's a little bit older than me. And so he was sort of still pretty junior when I was coming through there. But his work is, you know, obviously transformational. And so he was kind enough to come on my podcast. And one of the things that we were talking about was the MMR. And he's he's at he has a different role and a different personality. And he was able to speak a little more colorfully about the the very sad track record of the father and son team who, produced the really bad, poorly done research and some of the uh, ethically unsound approaches they'd taken, and demystify that. But we all know, look, there's incredibly good research around the MMR, how safe it is, how effective it is, and there's, I think, just such a substantial weight of evidence that there is no connection between it and autism, that it's really a tragedy that has come between people, caring parents, and their child, and the decision, to not give them an MMR shot. And I've had the opportunity to interact with parents who've made the decision not to go in that direction, later regretted it. And I can tell you, it's not because they don't care. They cared very deeply. It's because maybe we have not done as good a job during a long window where I think we kind of took the incredible success of vaccines as a medical community maybe a little bit too much for granted. And I think we also maybe forgot how important it is to parents for us to have engaged conversations with them around everything that touches their child. And we use the medicines and vaccines and so forth that we prescribe and administer, all the time. So we have incredible familiarity with those things and incredible comfort. And I think sometimes we maybe did not always, especially in my generation, invest as heavily in informed consent. I'm not saying that we did things without informed consent. I'm saying maybe we didn't spend as much time being the educator that is part of our role as a physician. So I'm not going to go into in any kind of depth the recent vaccine schedule changes that came out of the CDC 6 weeks or so ago, other than to point to some realities that I think are important for us to remember as we work with communities, or as we're working with individual families, parents around decisions on vaccines. First of all, none of our vaccines were taken away. Okay, none of them have moved into a category where they won't be paid for by all the paying sources, nor are there any new hoops that we have to jump through in order to be able to make a decision with parents to administer vaccines. So that's number one. Number two, thankfully, almost all of the routine childhood vaccines that at least that coincide with Ohio's required for school list of vaccines are still on the CDC's recommended list. And even those that are not, as I said, as long as we have a good conversation with the parents and they say, yeah, I want to get that, we can go ahead and administer those. So that's the bright spot in all of this. There's also another bright spot, though, for us. And that is that during the course of the last 4 or 5 years, there's been lots of research which has pointed to an erosion of confidence, an erosion of trust in just a whole host of institutions and various forms of expertise or authority. And that's regrettable. But one group that we really don't see that erosion taking place is there remains great confidence in physicians and especially in pediatricians. So parents still trust you. And so therefore, I think it's just very important in your clinical practices to continue to engage them with the caring and the sincerity and the expertise that that pediatricians have been exhibiting for many, many, many years. That's a legacy that's important. And I think it's a legacy that will be extremely important from a public health point of view in carrying us through this time period. So enough about vaccines, but I really wanted to underline the very important role that pediatricians have played and continue to play in the realm of vaccinations right through today. And I also wanted to underline that role as educator, because people really are looking for their child's doctor to be also the family's educator around the best health options for their child. Okay, well, some of the other preventative work that we do deals with the broad topic of healthy eating and active living. And, prior to starting this off, Claudia and I were talking about, an example of that, which is food as medicine, and various grants and programs that have existed over time around that, and some work we're doing right now at the Department of Health to try to work with other departments and the federal government to expand that. But there have been lots of efforts around that. The Ohio Department of Health, through its Creating Healthy Communities program, has invested very heavily over the years in this, to the tune of $38 million, in things like farmers markets, community gardens, rails to trails, playgrounds, et cetera. And more recently, one of the other real areas of serious investment, and an area where Ohio is actually a national leader and is called upon to, talk to other states on the national level about how to do this, is school-based health centers. And we have them all over the state. There are quite a number here in Cleveland proper. In fact, I just visited one about 2 or 3 weeks ago. But Ohio, especially under Governor DeWine's administration, under his leadership, has vastly expanded these. And the concept is one that just makes incredible sense. This is another area where pediatricians have actually been at the forefront of helping us bring this innovation about. And the genius behind school-based health centers is they're bringing healthcare to where the kids already are. And so talk about knocking down barriers. Many of the barriers to healthcare are just, they evaporate in the presence of a school-based health center. So parents don't have to worry about taking time off of work, which is a big deal. They don't have to worry about transportation, which is another big deal. Schools are places of familiarity, right? They're relatively, comfortable environments for kids and for parents. And so you don't have to worry about the scariness of going to some sort of unknown place, or God forbid, some place that is remotely connected to a hospital. And I could go on down the list. There are other things about school-based health centers that kind of just automatically remove barriers. But it boils down to the fact that in so many communities, whether it's urban or in our small rural towns, schools are very often kind of a known, trusted center of the community. And now all of a sudden, we've got healthcare right there. Well, now these have been so successful that they have really evolved first by, the faculty, the staff at the school kind of, oh, can I get seen? And pediatricians, being who they are, did what they could, right, to kind of help and make that possible. But and so as these have evolved, essentially they've become student focused and very often having a separate entrance where the public does not have to go into the school or place the students at any kind of risk for them to come in there. And so they've grown to be both student focused and essentially primary care for the community. And in some of our rural communities or underserved urban areas, that's unbelievably important because there may not be any other option. They may have to literally drive to another town to get to a primary care office or leave their urban neighborhood with, a bus ride that requires, multiple transitions. So it's been really important. And we're really excited about that expansion and to really the difference that that's able to make. And so another area, and most of that work, it's been in partnership with other agencies, but really the bulk of that work has been carried on through the Ohio Department of Health. By the way, we're now in almost 1,000 school buildings in the state, which is really impressive. Another area that we're leading the nation on is through the delivery of mobile healthcare. And most of that is very targeted healthcare, usually focused on vision care, dental care, and hearing. And those are really crying needs also. So, we're very grateful. We've got this new program, pilot program in 15 counties. Cuyahoga is one of them. In fact, I was just at a school right in the heart of Cleveland, I don't know, a few weeks ago for an eyeglass receipt by the students who are getting eyeglasses. And this is a program that is really powerful because essentially what OhioC does is this: brings a mobile unit to the school. And in some cases, the vision equipment rolls off that mobile unit and they set up in various classrooms and they become, eye doctor offices for the morning. And others, though, they don't have that accommodation at some schools. And we have mobile units where there are 2 bays in the mobile unit that are fully prepared bays for being able to conduct eye exams and then prescribe eyeglasses if needed. And here's the deal. In Ohio, like many states, we require vision screening in the grade schools. And we do a pretty good job of getting those screenings done. But anybody want to hazard a guess at how many of the kids who fail the screen and get a little note that says, Johnny or Susie failed their screen and they need to see an eye doctor? How many of those kids see an eye doctor? 37? 10? 37. What I like about 37 is the exactness of it. Okay. No, but you're close, but it's in between. It's right around 25%. So a quarter, it's actually 23 and change. So a quarter of the kids get any kind of follow-up care. Now, all those kids don't need eyeglasses. In fact, some of those kids will go have an eye exam and it turn out to be just fine. But actually a very substantial portion of those kids have something wrong with their vision. By most estimates, for most people, 80% of your learning is visual. So what are we doing? We've got a lot of kids sitting in classrooms who cannot see properly. It's bad enough that it's not uncommon at these rollouts when they'll hand the glasses out to the kids and they put them on for the first time. For kids to say something like what the one boy said at this Cleveland visit. So it was snowing when I was there. By the way, it was only snowing in Cleveland. So as I drove in and I hit, the Alderbrecht where 271 is, all of a sudden the snow started. And, then I get in, it snows the whole time. As soon as I leave, it's like a wall. I left Tuesday and then the snow went away. But so it was snowing and we're sitting in this room with big glass windows. Little boy puts on his glasses and he looks outside and his head flips and he goes, Oh, look at that. It's snowing. Okay, this poor little boy, he could not even see that it was snowing. How is this little boy? He was in third grade. How's he learning? I mean, it's miraculous if he's picked up, any reading or mathematics or any of what's been put in front of him. So, really important program. Essentially, we bring everything to the students. We do bill insurance. It's really hard, but we do bill. But the state is the payer of last resort. So if they're not on Medicaid, the parents don't have vision insurance. By the way, most insured parents, so parents with children who have insurance, rarely have vision insurance. They've got health insurance, but they rarely have vision insurance. I've had the privilege of, throughout my career, working usually for large health systems or for the state now. I've always had vision insurance, VSP or one of those things, but most working adults don't, and therefore their kids don't. So anyway, great program. We're doing great work. We're hoping through this pilot that's been funded to reach a very large number of kids here in the state, about 14,000 kids we think that we're going to reach. And that's just in 15 counties. Now we have the Rural Health Transformation Program, both school-based funding, school-based health centers and OhioC have both been funded through that to allow us to expand into rural counties here in Ohio. So good stuff there that we're looking forward to. Mention just one other program in our preventive work, and that's our Mom 365 program. And this is really oriented towards non-obstetrical providers. And it's really an education effort to help mostly primary care providers with their very important role of largely postpartum, being aware of and confident with how to identify and manage two important issues, hypertension, so postpartum hypertension, and postpartum depression. Two very important issues that sadly go unmanaged too often. Okay, I'm going to shift gears, and because I am sincere about wanting to leave time for some conversation, I'm going to move a little bit quickly through our urgent response. So the next thing that we do is help bring needed health care into situations that were unanticipated. The East Palestine train derailment is probably the one that would be one of our most recognized incidents. When that happened, we were among the first people on the ground. Literally a couple of days after it happened, there was a community meeting that was held in the high school gymnasium, and I was there in that gymnasium on the platform in the middle of the basketball court, and the gentleman from the railroad company who was supposed to also be there wasn't there. The people were really angry. It was, I'll be honest, a little frightening. But I recognized that they were frightened. They were hurting as a community, and they needed somebody to listen to what they needed to say. They needed somebody to hear about what they were worried about and hear their anger. And so I had, in a weird way, I really looked that this was a privilege to be the person there. I also had the benefit of, by that point, many, many years of dealing with situations kind of like that, just not of that magnitude. I'd never been in a room of hundreds of angry people before. But I walked away at the end of the night about 11 o'clock at night, having initially felt, again, scared when I first walked up there, to by the time I left, feeling like, wow, I mean, I felt like I'm a family doctor by training. You know, the way that every primary care doc wants to feel at the end of their workday or their week in terms of having ministered to or helped people feel cared about. So it ended up being a great experience. And the reason I'm sharing that, I'm not, my intent isn't to say, oh, look at the wonderful thing I did here. That wasn't why I shared that. The reason I'm sharing it was I'm trying to describe how important what we all do in the course of our day, and how, okay, I have no formal public health training, and yet I feel like I've been able to engage in public health very actively and effectively. And that's because we are all, I think, trained essentially to do what public health does. Or put it the other way, public health is just an extension of what you do in your clinical practices all the time. So as we reached out there, okay, that was part of the work. But then the other part of the work was actually delivering stuff they needed. And one of the things they needed was just healthcare. It was just water. It was just somebody go and test the water and find out, is their drinking water contaminated or not? So these were things that we were able to surge in. Ultimately, we realized that after a few weeks, our mobile unit couldn't just leave because they did not have an adequate number of primary care providers in that community. And if we were to just leave, it was going to leave a big vacuum and hole. So we worked with a local hospital and we provided funding and support, technical support and other supports to help stand up a primary care practice there that is there to this day. And so I think that after then a year and a half of very active engagement and investment with that community, we left it better than we found it. And we also were able to leave them in the hands of others because we were able to connect with national research-based medical centers that were able to bring some of their research personnel in to work with the community and continue studying the community and help us meet their needs into the long haul. There have been other things. I don't know if you picked, if the news of 2 years ago, there was a devastating tornado in Lake Logan, which essentially wiped the town out. I'd never really seen anything like it. But you know, we worked very actively. Again, we brought our mobile services in alongside the local health department and others to care for that community. Springfield, you probably heard about that. We have been very actively involved with that community. The big issue there was, you know, what hit the news was, oh, the Haitian immigration situation. Well, that really wasn't the story. The story was you had a community where the primary care infrastructure was completely overwhelmed. And so nobody was getting what they needed. And the Department of Health had to essentially surge in primary care services and help that community get back on its own feet. When at the end of the day, after we counted the large number of vaccines, I wrote them down someplace, but it's a remarkable number of vaccines, the number of people that we got enrolled into WIC who were on just waiting lists, all the things that we did, really, when we looked at the logs of information, the vast majority of people who received our services were longtime residents of Springfield. A small fraction of the people that we received care were people who were from a Haitian background. So the community had, yes, a large surge in its population, largely driven by manufacturing need in that community. So the manufacturers were it was a real blessing for them to have this, because it stabilized their workforce and many of the manufacturing businesses in that area. But it was like any sort of boomtown situation. They didn't have all the infrastructure they needed, and healthcare was one of them. We were able to come in and do that. Okay, finally, the other area that we spend a lot of time on, I'm not going to go through all the programs that we're engaged in, but we do a lot of work around chronic diseases and chronic disease, both prevention and improvement. Now, some of them are things like deploying programs to communities that help improve the remote diagnosis and management of hypertension. Sometimes it's work that's built around tobacco and tobacco cessation. We have all kinds of resources. But the work that we do, whether it's in cardiovascular, whether it's in stroke, whether it's in cancer prevention, all of that preventative and chronic disease-oriented work is really important and impactful. And we know that because the other thing that we do, and I'm going to show you a slide here before I open it up, is we collect vast amounts of data. And that data is used by research scientists all across the state. It's used by experts in various medical fields to understand the extent of various conditions and how best to act and intervene. But one of the things that we recognized, and that Governor DeWine has been absolutely insistent about, is, well, that's great, but if we don't get data out into as many people's hands as we possibly can, we're robbing ourselves of the opportunity both to have broader awareness of how important some of these issues are, but we're also robbing ourselves of the ability to have broader engagement in addressing and solving the issues. So let's start getting that data out there. And 5 years ago, we had virtually nothing that was anywhere close to being real-time information that was posted online. Most of our data was released in written reports. By the way, in that history thing that we have, it's fascinating. These reports back in the day were typewritten. They were on a typewriter, and you could see, just the work that had, and they like the spreadsheets and so forth, like on a typewriter. I mean, I just can't even imagine how they did. But anyway, we were still basically printing most of our reports on an annual basis. And, when you print a report on an annual basis, it's old news necessarily by the time you send it out. So we've worked really hard. And now if you go to our website, and I'm going to pull this up here. So this is our respiratory dashboard. And by the way, Claudia can confirm, I don't know the website for this, but I do know how to Google it. And so I just came in and I Googled Ohio Department of Health Respiratory Dashboard, and it went right to this. And so this is the kind of data I look at on a regular basis. So the public gets to look at the exact same stuff now that I look at. And there is volumes of this on our website on just about any topic. And actually, it's a little sometimes funny, sometimes frustrating to me when I get contacted by reporters and, so what's and I'll say, well, did you go to the website? Because it's up there. And part of that is, I want them to know about it. But part of that is I don't want to do their homework for them. But here's one that I really like. This is, okay, so what's going on with RSV, flu, and COVID? These are like our big three for respiratory virus season. And tells you when it was last updated. So it's always updated on Thursday. So it'll be updated today, but it's not usually updated till 2 p.m. Okay, so I don't know what today is going to show. I don't get any kind of like secret early information on that, because it's literally updated as we finally get all the feeds that come in. So nobody knows until that update happens. And what's particularly useful to me, oh, by the way, so what we do, this is all hospitalization data. And why? Well, nationally, we're no longer getting some of the other data that we were getting about purchasing of Tylenol, purchasing of thermometers, various light indicators that point to, well, there's increased sick activity going on out there because we're seeing those things go up. So that was kind of useful. We don't have that anymore. But what we do have, because we have an incredibly wonderful and robust relationship with the Ohio Hospital Association and the Ohio Children's Hospital Association. And so we have very accurate and very timely data about hospital admissions and the diagnoses that are driving those admissions. So it's pretty accurate. And if we know what's happening sort of at the apex of illness, we can make a pretty good guess about what's happening sort of in terms of the lower levels of illness. I'd rather have accurate and timely than have broader and less accurate information. Okay, so not as complete as what maybe would be perfect or ideal, but better than most states, and I think still pretty useful. And this is the one I really like, is I can go and I can look and I can say, okay, today's, did I knock it out? Okay. I can go and I can say, wow, 2/14/26. Okay, let's see, that was last week. And I'm looking here at the green line, which is flu. And you see, we had this big peak right around the holidays. You can also see, and I talk about this when I'm talking to the public, but we always have a peak every year around New Year's. And then it drops off. And then we have the bigger peak late in February. So, I looked at this year's Christmas peak, New Year's peak, and I said, oh, it's kind of high. Last year was a bad flu year. Okay. Look where we were last year. And then you come over to this year, ooh, we're like double. Message that I've been putting out is, look, we could be looking at late February or early March, a really big flu peak. It's also possible that this is a weird year and we had our peak and we're just not going to see much. That almost never happens. So I've gone back through the data over the last decade, and except during COVID, where everything was off, you go back, it's always this way. So it's hard for me to believe that we're not just in a trough and about to see a rise. Now, one of the things that reinforces that for me is that we now have reports coming from Europe for reasons I cannot begin to understand, because they're in the same latitude of the globe. They're usually 2 weeks ahead of us. So I don't know why that is. Maybe some of the ID docs know, but I don't. But they're usually 2 weeks ahead of us, and they're having their surge has just started. So that would suggest that the end of the month is when we're going to see our surge, which is not unheard of. So sometimes it does go into March. It's usually late February, but it might be that it's early March this year. Don't know. But the one good thing from a preventative point of view is, there's still a window of time to get the flu shot. And many of you know, I'm speaking to a pretty knowledgeable audience here, but no, the flu shot's not perfect this year, right? There's a mismatch. But again, the data, especially the great study from the UK that shows it's actually phenomenal at keeping kids out of the hospital. And it's pretty good at keeping adults out of the hospital. Not great, but okay. So it has a meaningful impact for severe disease for adults. It's got a terrific impact for severe disease for kids. So still a window to get that vaccine in if, we get the surge that we would anticipate. But this is the kind of data that's up there. And I would encourage you sometime when you're interested in something, especially if it's an infectious disease related something, or if it is a vector-borne disease something, or some of the big chronic diseases. Try looking at the ODH website. Try just Googling the topic and ODH and see what comes up. You might actually find a wealth of data, because we now post more topics of data than I can even begin to remember. And we were publishing none when I first walked in the door. So that almost entirely due to your governor, because he was beside himself that this kind of thing was not available. So I'll stop there. I don't know. There's like 5 minutes. I don't know if you wanted.
Thank you so much for sharing your journey and sharing what you do. We here at Rainbow really appreciate the Ohio Department of Health as we work with you continuously on different aspects of the work that you do. So it's just really great to have you here. And Amy, I think we are justified, because people were saying on the Infection Control Committee meeting that since flu was coming down, we should stop respiratory virus season precautions, and we were like, no, not yet. So maybe, so we can, we'll send this graph out to everyone on the committee. Does anyone have any questions or want to engage in a conversation? Dr. Worthington?
I was just wondering about, for this graph specifically, or any of the other ones, are these patients that are hospitalized with COVID or for COVID, or like with flu or for flu, or just?
Yeah. So they are patients who are hospitalized and have flu or COVID. May not be the reason they were admitted. And, we tried a long time ago to could we differentiate? Could we get data that told us, hey, this is an admission for flu? And in working with the Ohio Hospital Association, we can't. It's just not the way that things get recorded, but it's still pretty good to know, okay, that's one group where people are actually being tested, and people walking through the doors of the hospital that get admitted, here's the rate of positive flu that we're seeing, or COVID or RSV. Really great though this year to see the RSV being what it was. It was kind of, we had a couple of exhausting years with the RSV. So we were due a little break there.
I really appreciate your sharing your bio sketch and all of the different audiences that you've had to address in your life. I also appreciate that you called out we have credibility, and I think on individual levels with that patient sitting in front of us. And yet I'm sure that everybody in this room has had that experience of feeling the distrust, that sometimes very explicitly from family. So I wonder what you guys are doing around using social media to deliver information to the public and help restore trust. And that may be literally the hiring of influencers and the credibility of that person that looks like me from my neighborhood.
Yes.
The porch, or the Choose Peds campaign. I hear about commercials with success stories, and the tagline at the end is brought to you by your local children's hospital.
Yes. So it's incredibly important, and something that wasn't even on our horizon until a few years ago. I would be absolutely the worst person to guide thinking or decision-making around any of that. And I know that. Couple of things. We have hired over the course of the past few years, a group of people who are really adept at that. And I actually get every single week feeds about the number of social media hits and so forth. And I mentioned, for example, that podcast, not my idea. That was people, half my age who are really smart and knowledgeable about this who said, you need to do this and, set it all up. And, so, but more importantly for the social, like just social media feeds, we're even doing things we're working with an ad agency and are very close to launching some ads that are targeted to social media and pop up as these like little irritating blurbs that people have to like endure, but they're very short, they're very funny, and they our first ones are going to be on vaccination. The first two, and it's very close to having final approval and launching, but they're different from each other, but they're both heartwarming and funny, and are research based. So we've been able to work with experts in what resonates with social media audiences, and it's been tested and so forth. So we're doing that kind of thing. And just a wonderful group of people who work in our shop. It's one of the many areas that I'm really proud to see us moving in. And even as I recognize that whatever we do right now, I'm sure it'll have some impact and some benefit, but we're going to constantly have to be learning and growing from whatever comes out because it's a really new space. And I think that how we approach it is going to have to evolve as we learn in that space.
I'm going to read a question for you online.
Yep.
As a pediatric endocrinologist, wondering about the statistics on the newborn screening. There are recent case reports on missed congenital hyperthyroidism in the literature. Are there any significant, hold on, I got to scroll down. Any significant recent changes or trends in performing or refusing newborn screenings in Ohio that pediatricians should be aware of?
First, I'd say that's an interesting specific question that you have. And what I'd like to do is so we've got a panel of physicians who are experts in newborn screening who guide all of our work on newborn screening. I'd actually like to take the thyroid question in particular back to them and get you an answer from people who are really expert on that. So, Claudia, can you assist me with getting that? And I will have
get it back to our endocrinologist.
Yeah, I will have, the physicians who, focus their careers on that help with that answer. But broadly, what I can tell you about newborn screening in Ohio is it's alive and well. It seems to be very well received. The pressure that we get, if anything, is around expanding our newborn screening, despite the fact that we are one of the leading states in the nation in terms of the number of conditions that we screen for. And we are also one of the leaders in the nation in the application of genomics in the screening process. So we almost, wherever there is a PCR genomic-based option, we use it. And we continue to push for and expand the horizons on that. There are a number of conditions where we're one of only a handful of states who even screen for the condition. So area of real leadership for Ohio.
Yeah, that's true. We worked with your team about 10 years ago to get SCID screening for immunodeficiencies at birth. And I think we were like the third.
Yeah,
state in the
on many
nation.
of these, we're like the first 1, 2, or 3 states to.
Much more broad and somewhat ignorant question, but I'm curious about your role and scope. How much of these programs that your department runs are internally generated in response to, a broad mandate to improve Ohio's health, and how many are specifically set forth for you by the governor, the legislature, federal programs?
Yeah, so I would say it is a mixture of all of the above. I think one way to think about what the Ohio Department of Health does is to look at our budget. The vast majority of our budget, in the neighborhood of 90%, give or take, in any budget cycle, comes to us through federal funds, most of which come through Health and Human Services. There's some other agencies that fund us, but HHS is our number one funder through mostly the CDC. And the next biggest funder is the State General Revenue Fund. And that constitutes, around, just shy of 10%. And then there's 2 or 3% that's from various philanthropic sources. So that's kind of how we're funded. Now, many times, so we're very, that kind of funding tells you that we have become very adept over the years at applying for and successfully receiving various federal grants and funds. That proved also to be true with the recent Rural Health Transformation Program, where I think we did comparatively very well, based on what percentage of our state is rural and so forth. So our total budget, if you include the Rural Health Transformation Fund, now is well over $1 billion. So about 900 million of that is coming through the federal government. Those programs, how do we identify them, and how do we end up having folks who are working on that? It's almost always the case that there is a demand for pursuit of an issue that then leads us to form a working group that then pursues a line of funding. And then once we have that line of funding, it formalizes into something that's actually a formalized group inside of the department. That can come from the legislature. So we have had the legislature actually write legislation that says you will do the following. I only know one governor. I've only worked, well, I knew Governor Kasich, but I have only worked under one governor. And I can tell you, he is particularly around kids and children's things. He's very involved, interested, et cetera, and has driven us to add and expand a lot of things. I mentioned school-based health centers. I mentioned Ohio C. I could go on down the list. So a number of things come directly because the sitting governor says, I want this to happen. And then the federal government is through HHS and the CDC very often saying, look, there's this initiative that we want to pursue. And we'll look at that and we'll say, well, yeah, that looks like a pretty important opportunity. We should get involved with that. And then finally, we work very closely with the local health departments, the Ohio Children's Hospital Association, the Ohio Hospital Association, and the various medical specialty bodies in the state. And, very often they'll say, we need collectively to be doing this. Best example I can think of is stroke. So it was really a physician-driven need that led us to become part of the Coverdale Stroke Network. Interestingly, then, like in the last General Assembly, the legislature also said, we will have, well, we already had it, but it was written in. But it was because of work that we had done with the medical community around stroke and identifying stroke and coordinating stroke and doing a better job at assisting communities in moving quickly to address stroke the way that we do heart attack. And I can go on down the list. We've had, work with sickle cell disease that has largely risen out of the medical community, cystic fibrosis out of the medical community. So it's a mixed bag.
Well, we are over time, so thanks everyone for staying. If you have more questions and time, please join us in the community room. We have some breakfast and we'd love to share it with you and our speaker, Dr. Vanderhoff. Thank you so much. Oh, that's right. And the all important CME code. Thanks to everyone for joining.